A 58-year-old man presented to the emergency department with sudden onset of severe abdominal pain, bloating, and nausea. The pain was diffuse and crampy, without specific aggravating or relieving factors, and was accompanied by vomiting. He denied changes in bowel habits, fever, or recent dietary changes. His medical history included hypertension and type 2 diabetes mellitus. 3 weeks prior, his primary care physician had started him on an ACE inhibitor, lisinopril, for blood pressure management. On physical examination, the patient appeared to be in moderate distress due to pain. His abdomen was mildly distended and tender on palpation, with normal bowel sounds. Vital signs were notable for mild hypertension and a slightly elevated heart rate. Laboratory tests, including complete blood count, electrolytes, liver function tests, and pancreatic enzymes, were unremarkable. A computed tomography scan of the abdomen was performed, showing diffuse bowel wall thickening without signs of obstruction or perforation. Based on these findings, the initial clinical diagnosis was gastroenteritis, and he was treated with intravenous fluids and antiemetics. Diagnostic error explanation. The initial diagnosis of gastroenteritis did not account for the patient's medication history, particularly the use of an AC inhibitor. Visceral angioedema, although rare, is a known but often under-recognized side effect of ACE inhibitors. This condition can present with symptoms similar to those observed in this patient, including sudden abdominal pain, nausea, vomiting, and bowel wall thickening seen on imaging studies. ACE inhibitor-induced visceral angioedema occurs due to increased levels of bradykinin, which can cause localized swelling of the intestines and other visceral organs. This condition does not always present with external signs of angioedema, such as facial, tongue, or peripheral swelling, making it easy to miss without a high index of suspicion. The patient's use of lisinopril and the exclusion of other common causes of abdominal symptoms should have prompted consideration of this rare but significant adverse effect. Prompt recognition and discontinuation of the ACE inhibitor are crucial for resolving the symptoms and preventing recurrence. The failure to consider visceral angioedema in the differential diagnosis may result in continued symptoms and potential complications. This case highlights the need for clinicians to be aware of and consider medication-related adverse effects, especially when new symptoms arise shortly after starting a new medication.